At Creo Medical, we believe energy has the power to transform lives. In the field of therapeutic endoscopy, no other company is doing what we are with energy. Our innovative Comaptive technology combines multiple energy sources within our Chroma energy platform. Bipolar RF and microwave energy are precisely controlled to enable our patented suite of flexible, miniature endoscopic devices to deliver clean resections, precise dissections, on-demand coagulation, and controlled and consistent ablations. Optimizing, not compromising. We are reimagining therapeutic endoscopy, delivering the option to deal with an issue immediately rather than refer. It's game-changing, a paradigm shift. And it's less invasive, safer, and offers less tissue damage, so it makes for quicker healing, improving patient recovery times and quality of life. It's better for the patient, better for the clinician, better for the hospital. We're inspiring the next generation of clinicians to ensure that in the future, more surgery will be carried out this way. And by building partnerships, we'll introduce Comaptive into a wider range of applications, turning the improbable into probable and making the impossible possible. Open your mind to Creo Medical, transforming energy, transforming lives.
Good afternoon, everyone. My name is Andrew Bell. I'm the Head of Professional Education at Creo Medical. Thank you for taking the time to participate in this webinar, which is going to be the first in a series of events where we're discussing SSD, or Speedboat Submucosal Dissection. This first event is going to be focused on the learning journey from Advanced EMR to SSD, and we're grateful to have three excellent faculty members joining us today. We have Dr. Zacharias Tsiamolis from East Kent University Hospital. We have Dr. Rosa Vega from UCLH, University College London, and for Beintaris, who is from North Tees University Hospital. And they're going to share their personal experiences of their own journey using the Creo education pathway, and share some cases, some videos, and hopefully have some lively discussion around their journey, what they've done, and hopefully engage yourselves with our clinical education program. Just going through the agenda, we'll start off with Zach going through the SSD and also the value of the education program, and then Rosa and Joseph will talk us through their cases, the journey that they've recently gone through from EMR to SSD. Please, we'd like to make this as interactive as possible. So there is a chat function on the Zoom that we're all on. If you please leave a question on there, what we'll try and do is either during or more likely afterwards in the Q&A section, we'll make sure that those questions get answered. And if we do run out of time, we'll make sure that someone from Creo or one of the faculty members reaches out and answers your question directly. So on that note, I'd like to hand over to Zach, who's going to take us through the first part of the agenda.
Thank you, Andy. It's a great honor and privilege to have my two esteemed colleagues, Rosa and Joseph, to share our experience and to discuss the journey from the Advanced EMR to the SSD. I know it's a quite new terminology, but I think the world has to get used to that because it looks very, very promising and and provides very good outcomes to our patients. I want to thank you, Andy. Thank you very much for the kind invitation as the head of the professional education program and also all the senior management of Creo Medical. So my journey started back in 2009 when I was a fellow at St. Mark's, and I delved into the advanced endoscopic techniques, mostly on the wide field EMR. But during this time, I was also I had the really honor by Professor Van Saunders to to have my MD research at Imperial College. And the title was Endoscopic Excision of Precancerous Complex Colon Polyps, Improving Outcomes and Developing New Instruments and Techniques. And one of the instruments that I heavily participated on the development was the Speedboat Inject. In parallel, simultaneously, I was actually had again and then the opportunity to visit in terms of the fellowship, the National Cancer Center with Professor Saito, and to split that training in 2 periods. And during that period, the 2 periods, I was exposed on the live training during the CAN course as a continuing professional education. So all these things, you know, we managed to, with Andy, to combine and create this lovely learning curve. This is nothing else, just my experience and also the innovative also initiative from Creo Medical. So we look to personalize training, to be immersive, to have dedicated courses, but mostly and mainly we managed to establish within pioneers to mentor, which was lacking from the worldwide ESD curriculum. So we managed to create and break down the training curriculum in 4 phases. The phase 1 is the trainee to understand and orientate himself on the technique and also on the technology. Then that followed by really intensive weekend with the didactic lectures and hands-on experience with no interference by the trainees, but by the trainer. And then following that assessment of the weekend, after discussing thoroughly the performance of the trainee, there was a very thorough mentoring program to support and to advocate and to sort out the logistics issues to all the colleagues that they were wishing to proceed with the SSD. And then we're now, I think, the only group that we have managed to run this course since 2018, so almost now 3 years now. And we do, and really I'm so pleased to have colleagues not only in the UK that are here with us, but also in the United States, in South Africa. And that was really so an excellent feeling from my point of view. And I think last year we had the position statement from the European Society about the ESD learning curve, and we can see thoroughly it is actually what we have implemented already for the last for 3.5 years, but with a slight difference that we have managed to blend the learning curve and to have a paradigm shift on the learning process. We managed to have a full exposure with live animal exposure during the weekend, and we had to have physically or virtually mentoring our colleagues. I think we're still being pioneers even on that note. And it was very easy. It was very easy to achieve all this because we had in our hands an innovative technology, a novel design, a new device, not a knife, a new device that we can cut using bipolar radio frequency and could coagulate all the vessels with using microwave. And just briefly, the difference between the bipolar and the monopolar, it's only one. The return plate that we are accustomed, to use during the monopolar radio frequency, it's not. It doesn't have to go through the tissue evidence of the body. So the forces that we have to push, they are less because the return plate is being actually embedded within the device, which means you have less need of voltage to push the energy, and that results in minimally localized energy pathways and no options of remote burns. On the other hand, the microwave energy, quite intriguing and quite innovative. It's a radiating electromagnetic field. So the microwaves, they can cause really oscillation of the water molecules, that causing friction, and that friction resulted in bursting. So we managed to control all types of bleeding, oozing, active bleeding in a slow heating process, and which is always controlled by the design of the instrument, but also it is time dependent. What really makes challenging is, for the first time, we do have on the submucosal dissection, we do not have another knife. We do have a 3D dimension design. We have length, we have width, and that gives to the operator more stability. I mean, based on this design, the operator can activate different parts and can utilize these parts as required. So the Speedboat Inject is the first advanced multimodality device. And this device optimizes the endoscopic submucosal dissection performance because of the precision of the bipolar energy, because of the controlled coagulation, because of the protection of the muscle bed due to the less need of voltage, and minimizing the need of a change of instruments. So all this, the Speedboat submucosal dissection brings the repatriates the original, the authentic Japanese ESD to the level, to the deep level of the submucosa, performing above the muscle layer, comprising 6 modalities: cutting, coagulation, injection, rotation, insulation, as well as stability as a surgical instrument. And this gives us the confidence. It will boost us to perform and push the boundaries to perform endoscopic protectomies very safely, in a timely manner, and at the same time to move proximally and remove circumferential endoscopic sigmoid descending colectomies, where the patient can go home the same day. This is definitely a paradigm shift on the patient's pathway. And we manage, and we are in a great position to share all this fantastic clinical education program with my 2 esteemed colleagues. The first one we actually met is Dr. Rosa Vega, who is a consultant gastroenterologist and interventional colonoscopist at the University College of Hospital in London. And I would be delighted, Rosa, if you can really speak from your heart and just tell us exactly what was your experience.
Right. Thank you, Zach, for the very kind introduction. And during the next few minutes that I'm going to be talking, I'm going to try to share my sort of a case study as a clinician that has gone through this training and mentoring program, just to share with you that the impossible is possible. Anyway, so that's my first slide, and it's just to talk you through the different steps of this mentorship program that Creo Medical is putting in front of you if you wish to uptake into SSD training. And just to summarize a little bit how my progress went, I have created this slide. So I was, or I am, an advanced interventional colonoscopy with quite broad experience of wide range complex EMR of large non-pedunculated lesions, and I had been leading this service in my hospital since 2010. So I had a reasonable broad experience into interventional colonoscopy, but never went into training on endoscopic submucosal dissection. And I did my first Speedboat training course with Creo in 2018. And I really felt that was a step forward for improving patients' outcomes and patients' care. After that, I went through a quite of a time-consuming, because it was the very first time I tried to set up this service, of putting a sort of a business case and approve this new service with my local hospital, and trying to understand what was needed, not just from my personal point of view as the training and skills that I needed to adapt, but also what the hospital and the service that I was part of needed in order to support the whole robust service that we were developing. And finally I got the approval in May 2019, because it took a bit of time between my speed training course in 2019 and the final approval. I had a refresher course provided by Creo Medical on animal models, and also that gave me the opportunity to train the local endoscopy nurses that would be also part of the team in September 2019, and we did the first case on the 10th of September of that year. On that first case, Zach came as my mentor, and we did about 5 cases together, that he was coming to my unit and supervising me while doing the first 5 cases in humans, and then I was able to fly solo and start my cases on my own with either remote mentoring or mentoring sessions that we were doing every few cases, just to review outcomes and so forth. So far I have managed to do 30 cases in patients. The last 15 have really been over the last 3 months, mainly because of the pandemic slowing down the service and then having to catch up with patients waiting for the treatment. I had the honor to present a live demonstration on the London Live Endoscopy course in 2020. And since in September 2020, I have become an SSD trainer on ex vivo and in vivo animal models along with Zach. So we are providing this training, 2-day training courses together. And just moving forward, that has taken into other colleagues having done the training course and starting to perform their first human cases, and again I've been honored to mentor them on those few cases in their local hospitals. That it's been a very interesting experience for me as well. So the highlights of my journey, I would say that you have to be ready to learn a completely new skill. Even if you think you are an interventional colonoscopist, that you can do a broad therapeutic procedures, SSDs are a completely new skill, not just from the technical point of view, but also from the sort of intensity, psychological and emotional point of view, especially if you are a physician and you haven't gone through the emotional learning process of being a surgeon and the potentially facing of complications to patients and so forth. So I think you have to be ready and dedicate the time and energy on that. Also, I think engaging the hospital management in the journey is extremely important. So if they understand the service you are trying to set up and how it's going to improve patients' outcomes, it's very important and really facilitates the whole setup. Obviously, you have to be prepared to look for funding for these cases, the clinical support team, so you will need your surgical colleagues on board to try to understand the indication of submucosal dissections and where they can stand and support you on these cases. It is important that nurses that assist you in endoscopy feel part of the team, feel part of the new service and go through the training. And also at the beginning, you are not going to be very fast, so you have to adapt the endoscopy availability to these cases as well and talk to your colleagues so everybody is on board. I would say that the patient care and outcomes are paramount, and also involving patients sometimes in decisions or even designing the patient information leaflet explaining the technique is very important. And lastly, case selection. Try to choose the cases that you can chew, especially as you are at the very beginning of your development course that I am still considering, because 30 cases is not very large number. And a multidisciplinary decision is also quite important, because then you have your surgeons, the radiologists, the pathologists, even the nurses assisting you. So all that is important. So involve as many people as possible if you are planning to take on a similar journey. And now what I would like to do is just to share very quickly the patients I did. So a total of 30 patients have been done, and you can see the average age was 65%. The patients were either referred by the bowel cancer screening program that exists in the UK, or through a cancer referral pathway where patients that there is a suspicion of cancer, the general practitioners send with a sort of a rapid pathway, and they all have a fit test positive. The average size of the lesions was 45 millimeters. I managed to remove 20 lesions.
Rosa,
Yes.
can I ask you a quick question, please? Because you mentioned about the case selection, and then you mentioned, because the previous slide, you mentioned about some Q-fit positive patients through the bowel cancer screening. So can you give us more information about the case selection? So did you go with the flow? Did you actually start with easy cases? Did you go with the difficult cases? Because we know that you've been an expert on advanced wide field EMR. So what was exactly the case selection? So what was the hint there?
So all the patients that I proposed SSD, we have a sort of a multidisciplinary forum that we call it an MDT in my hospital, where we have surgeons, radiologists, pathologists, and other gastroenterology endoscopists sitting in that panel, and we do all the pre-screening needed to ensure that the lesions are not transmural with MRI scans of the rectum and so forth. So that was the first sort of a step to ensure that we were not putting through an SSD lesions that perhaps were beyond SSD benefit. And I would say that probably the very first 2 or 3 lesions, especially the very first one, was a little bit bigger than probably I would have been able to tackle on my own, but it was a very good advantage that you were there, sort of supporting me step by step, and that gave me the confidence. I think that as you are getting exposed, and the importance of having a mentor then allows you to the cases much better, so then you are more successful in sort of a complete resections. I don't know if I have asked the question.
Yeah, did you find useful to discuss the case with your mentor? Is something that you would like to discuss?
Absolutely.
Yeah. Okay. All right.
Absolutely, and also I'll explain you an anecdote in one of the cases I want to present later, that actually having had another case with you really highlighted the point of a problem that I was having. So from the 30 lesions I resected, 20 lesions were removed en bloc, and 10 lesions I had to use a hybrid technique, either because the lesions were maybe too large or because there were some problems of fibrosis. Interestingly, from the 20 lesions removed en bloc, 4 of them had SM1 cancer, and only 1 required radiotherapy because there was lymphovascular invasion, but the other 3 spared any other further treatment. And interestingly, on the lesions that I had to use a hybrid technique because there was fibrosis and it was proven difficult to sort of dissect it completely, 4 out of them had invasive cancer and needed surgical treatment. So all the time, that made me reflect that when things are not straightforward, to be concerned that perhaps the treatment is not going to be the definite treatment for patients. In terms of complications, and I'll talk you through some of the cases. On these 30 cases, I had one case of perforation, and I was able to resolve it just with endoscopic treatment with clips and prolonged antibiotic therapy, and the patient spare surgery. That I think it's probably due to a combination of using a device that is quite safe, because of the characteristics of the way the energy is being delivered, and also the insulation hull, that you can go closer to the muscle layer, and also with the training and mentoring program that helped me to identify better the plane that I was. Anyway, I'll talk you through very quickly through few cases that I've done, just to demonstrate that things are possible with images. So this is the very first case that we did together, you and I, Zach, and it's quite interesting because it was in the rectum, large, bulky, probably not looking tremendously concerning in terms of invasion, but I felt a bit daunting that perhaps was a bit too big. But having you around allowed me to dissect it, and when I look at this scar, I can see that there is still a bit of submucosa around it because it was the first case, and maybe I was a bit concerned of going too deep to the muscle layer, but it was removed and blocked, there was no cancer, and that was the start 6 months later with a fantastic outcome. And since the patient has been surveyed once more for, according to our national guidelines of screening for polyps post polypectomy, and it's all clear. This was a second case that we did together, and it was very close to the anal verge, and I had to use an adult colonoscope, which kept me with a lot of instability, especially because I had to work on frontal view, not being able to retroflex with the adult colonoscope at the time with my sort of a second case on board, but still managed to remove it and block. Didn't look very pretty, but actually the outcome was also very good, and that was the 6 months surveillance colonoscopy with no recurrence whatsoever.
Yeah, on this no, Rosa, you're right. Based on the previous scar, when it was really again complete dissection, but on the uniform submucosal level, with deep submucosa, the scar looked really nice, it's smooth. In this case, because of different levels of dissection, you can see the scars are different shape.
Exactly.
Which explains that. But honestly, with the colonoscope, wow! I mean, that was quite a.
Yes, and it was the second case
Yes.
I did. So yes, and then obviously you move on, and then you start improving, becoming more confident, and in that lesion that was a granular LST in the rectosigmoid junction in a quite young patient, you can see I'm starting to develop confidence. I'm going right on the muscle layer with very nice and neat dissection, and again the follow-up afterwards with no recurrence whatsoever.
So, Rosa, sorry to interrupt you again. I will insist on the scar, okay? Because based on my cases, which I've shown you before, a bit larger cases and a bit circumferential, I haven't encountered any stricturing, and there is some luminant narrowing, it's a circumferential, but there's no stricturing for some reason because of the protection of the muscle bed. I think that, or even the bipolar energy per se, there's a really, I would say, sleeker proliferation of the epithelium, and you can see again on this, on the right hand side, it's so smooth. Can I ask you how long was that? The follow up?
It was 6 months.
Yeah, you see, in 6 months, previously with the monopolar devices, I mean, you can see still the granulation tissue trying to, to cover the scar. But this is beautiful. So I think there is, based on the technique, as I mentioned in the profile, it really has an impact, a positive impact on the scar. Thank you.
And then obviously you are starting to become more adventurous and just taking on lesions that are a bit larger. That was a very large sort of a sessile lesion again in the rectosigmoid junction, and it came out also quite nicely en bloc. With no problems whatsoever, and the patient extremely grateful, because all these patients otherwise would have either higher chance of recurrence or the possibility of facing a low anterior resection with all the long-term symptoms that patients develop post-surgery. I wanted to share this case. So this case, already the picture looks quite worrying with all these sort of retractions, but it was extremely close to the anorectal junction, and the patient was wanted to try if we could remove it endoscopically, so he could spare a proctectomy as a result, with an end colostomy as an outcome. And obviously we already knew that the possibility of high-grade dysplasia or intramucosal cancer was extremely high, but the MRI scan that he had didn't demonstrate any invasion. But actually, at that point, I found this, and you can see I am in the submucosal plane. The round plastic is the cap that I have at the tip of the scope, and I saw this pyramid of white stuff in front of me. And what I was mentioning before, Zach, I don't know if you remember I think the third case that we did was a patient that we did together, was a patient that already had an attempted endoscopic mucosal resection and had a recurrence that the physicians in the hospital were struggling to keep under control. And you were with me in the room, and the patient had exactly the same feature, that is the muscle retraction sign. And I was able to identify it on my own because we experienced it together. And obviously the lesion was unresectable by SSD, and the patient had to undergo surgery. But I think the mentoring session we had together allowed me to then, on my own, be able to
Rosa, can I just interrupt? I was about to ask, because it's, as far as I read at least, it's quite a rare sign, the muscle retraction sign, to identify. But you've answered already. I think in these cases, particularly at the start of your learning curve, you really needed the input of a mentor. Zach, how common is that sign? I mean, what's your experience?
I wouldn't say it is uncommon. I mean, the more cases you do, I think sometimes you, at the beginning, you possibly overestimate the muscle retraction sign, which I did also. And then, the definition, because this is, for example, in this case, it really looks very malignant. But the more, when you encounter more and more fibrosis, which is a benign fibrosis, then you become more familiar. So initially you say, oh yeah, this is a retraction sign. It could be, but it's a fibrosis. So the muscle retraction sign should be, in a way, be vigilant that if you have fibrosis, you may encounter that, and you must be very careful at that moment, because the cutting point is so, you have to be very careful, because you can go through the muscle layer. So I think the more you get more cases, you'll be able to differentiate the benign fibrosis with a muscle retraction sign based on the malignant invasion.
So, and I wanted to also summarize, thinking, I used to perform large wide range EMRs and probably do them relatively quickly. With the SSD, you need to take a bit of time. And what are really the benefits of Speedboat submucosal dissection? And I will illustrate it with a very quick case after. But SSDs is a preserving curative treatment, for instance, in patients with submucosal cancer. Because if you get the clear margin, the patient avoids surgery and the resection of bits of the bowel. And the complication rates is much less than conventional surgery. in my case, because I've gone through the training and the mentoring, even my complication rates are quite low. I had one perforation sorted endoscopically in 30 cases, which is not bad at all, and in keeping with the sort of key performer indicators of endoscopic submucosal dissection. And also because you are dissecting quite below to the EMR plane, you have a better histology staging as well, because if you have cases of high-grade dysplasia, maybe cancer, because you've got more submucosa to analyze. The pathologists seem more pleased when they receive the specimen to give you a more definite outcome. And obviously, if you remove and block large lesions, even in the absence of cancer, we all know the recurrence rate of adenomatous tissue in piecemeal EMRs, isn't it? We all have these patients that have been coming over and over with recurrent lesions, and actually removing them en bloc with SSD avoids that. And patients prefer it. So if you can offer a treatment that is going to cure them, that is going to preserve the organ, that they are going to spend maybe one night in hospital or leave on the same day, depends of how you feel, and possibly slow down in the number of surveillance colonoscopies they need, it's all in favor. So patients are really on board with a technique as well. And a perfect case that summarizes that is this case. So this is a patient that was 81, that was referred to me because of episodes of bleeding, had this lesion, that the lesion wasn't extremely large, probably 2 centimeters or so in the mid-rectum. But when you were analyzing it with a narrow banding imaging properties of the scope, that is the picture number 2, you could see there was a bit of disorganization of the pits, and also the surface of the lesion didn't look nice and smooth. It looked like it's been sort of munched around, and it looked already suspicious. We did the MRI scan, we did all the tests to ensure that there was nothing concerning before we proposed to the patient to have the SSD, and we went ahead. And I performed an SSD that was right to the muscle layer, and you can see here the scar, and it was removed en bloc. And the histology results demonstrated that it was a cancer, an SM1, but with a margin from the cancer to the muscle layer of more than 1,000 microns. So therefore, the patient was cured and spared of further surgery. And I think the impossible is possible. And when you have patients that they are maybe elderly, but they still have a good performance status, and you can cure them with this technique rather than proposing an ultra low anterior resection and so forth. It's a fantastic outcome, and I just would like to finish with this case to highlight what the benefits are of the SSD.
Can I just make a comment? And I think that will be useful and will be food for thought. I don't know if you can hear me well, because I can see my face moving a bit slowly. You know, for this type of cases that have been discussed on the MDT and there is suspicion of cancer, I was really impressed by my surgical colleagues. And now the last 8 months, we run joint consultations with the surgeons. And I was really impressed and surprised when they brought a terminology, which is, I was really shocked, as a diagnostic ESD, which is very common, you know, in Japan. When I was in Tokyo, you know, when they were not sure, because, you know, we say that this might be type 2B, it might be, because it's not type 3, it's type 2B, this lesion, but still you're not really confident that this is really cancer. So we have first the consultation with the surgeons, and then the outcome of the MDT is to perform a diagnostic ESD since the patient is old, he's not so fit for surgery, and then you have a proper specimen. So I think this is very new, new kid on the block, even for my service, and I really enjoy that, because then the patients, they get all the information from the surgeons, and I think this is very, very important.
Yes, absolutely, and it's the point I was trying to make, that at least for staging, it's also an advantageous procedure, because even if you have cancer or the patient has lymphovascular invasion and requires further treatment, you get the proper staging, and you may spare the patient from further treatment if you've managed to get a deep margin that is an R0 as well. So yeah, completely agree with your point. Okay, so that's my journey, and I would like to hand over the baton to Dr. Joseph Beintaris, that he has gone through a similar journey as well, and if you can tell us your experience that maybe differs a little bit from mine, and we can all enjoy that.
Indeed, thank you, Rosa, for the introduction. Okay, I've got control, that's great. So basically I've used your slide in order to demonstrate what my journey has been so far. Obviously it's a bit shorter than yours. I'm a bit earlier on the learning curve or the SSD journey than you are, Rosa, and definitely in comparison to Zach. So similarly, I had been performing Advanced EMR for a few years before I started working in the submucosa. I completed my specialty in 2014, and I did have some exposure, mostly assisting, and up to that point. After that, I started doing my own EMRs. Eventually, I started working in a less extensive trust than yours. Basically, we didn't have so many disciplines or so many open-minded surgeons and colleagues in order to discuss minimally invasive operations like SSD in Northeast. I did my first training course on SSD after consultation and contact with Zach back in 2018. It was on an in vivo animal models back then, Zach, as you remember. Quite intense course, quite a few cases. I mean, Friday and Sunday found me a completely different operator. Although I caused a couple of perforations during this learning curve, and also I also managed to remove some lesions and block, which basically I was over the moon about that. And I managed to start thinking about my therapeutic skills in general, submucosa or mucosa aside. I think it's important that if you engage with the submucosa, you start in seeing therapy, polypectomy, in a whole different manner. Then I did another effort like yours, Rosa. I started to introduce this procedure in my trust around June 2019, and I got approval following quite a bit of paperwork, as I'm sure you'll agree. It had been a bit of time between my first course and my actual first case. Therefore, I kindly undergone another SSD refresher course, including with one of my nurses in October 2019. And then I performed my first cases. The first two cases were face-to-face with mentoring by Dr. Tsiamoulos, and my 4 cases thereafter, because of the COVID pandemic, have been performed with mentoring in a remote fashion. As I mentioned, my first case was in 2019 in June, and I'm still undergoing remote mentoring sessions whenever I'm booking cases in Northeast to discuss their management there and then, and obviously to debrief and discuss the outcomes and my progress with Dr. Tsiamoulos, who remains my mentor. Overall, my clinical experience with SSD, 6 cases to date, quite a few fewer than yours, obviously, Rosa. Of those, I've managed to resect 3 and block, and in 3 cases, I had to also use the snare, a hybrid approach. From those cases so far, 1 proved to be a malignant polyp. I have added a few cases there just to explain some learning points that I benefited from. Basically, this is my very first case of SSD that I did at the in my trust Northeast. This was a case of a rectal lesion that was referred by a fellow bowel cancer screening endoscopist, very, very experienced. It was referred as a 3-centimeter rectal lesion. I had organized everything, I thought, perfectly. General anesthetic, surgeon standing by, my mentor was there. When I started assessing the lesion in a bit more detail, and I hadn't done this myself to begin with, I realized there were areas of JNet 2B there. That means we were probably dealing with at least a high-grade lesion with potential superficial submucosal invasion. Eventually, we did the lesion. Zach was there. We removed it. I did have to resect the last bit with a snare because of time constraints. I mean, the whole lesion took about 4 hours to complete, and you can imagine the pressure Rosa and Zach in a trust without previous experience on minimal invasive techniques like this. The polyp proved to be a high-grade lesion. My learning point from this case, and which I have implemented since, is that I tried to assess the polyp myself because, I mean, we all have very, very experienced colleagues. But if you assess the lesion with a view to treating and you rehearse your steps, assess the axis and the pit pattern very, very meticulously, you may end up with surprises. This case, for example, might have been a bit too advanced for a very first case in my trust. All well, the patient was fine, total excision of a high-grade lesion with clear side checks. Just wanted to put this on the table. It's important to assess the lesions yourself, or at least if there is a team of more than one operators, with somebody who knows the classifications and the implications to staging. The second case I did, I'm still arguing with Zach about that. It was a 25 millimeter, not too big, mid-rectal lateral spreading lesion, which was non-granular. So I was expecting to deal with a high-grade lesion, probably fibrotic. These NG lesions often are fibrotic, and indeed, I did encounter fibrosis in the area of concern right in the middle, this yellow area there. So I had to go a bit deeper, mostly intentionally. Towards the end, I think I probably overestimated my plane, and I caused this defect there, which I'm sure any EMRist would agree is quite scary to see. I did have Zach mentoring me for this case, albeit remotely, and we discussed it within a couple of minutes. He did explain, I mean, muscle tears are not that uncommon. I was in the rectum, so even if that was mesorectal fat, it's not the end of the world. So instead of dropping the lesion, I persevered, completed it. I won't lie to you, I did clip this in the end. I put a couple of clips there for peace of mind, for my own benefit mostly. The patient did very well, and the polyp proved to be a tubular high-grade adenoma. I guess the learning point here is that it's important in your very first case is to have a mentor who has seen all these appearances before, who knows how much you can push your limits. And indeed, in this case, I think it was, he saved the day. What do you think, Zach, by the way? Was that mesorectal fat there? I always ask him this question.
My only concern is that when we did the lesion was virtually, and I think what I don't know if you remember, there was not so good, the platform was not so good, so there was deflection of the light. I think you know, it's a good learning point because whenever you perform the submucosal dissection, you must be able to cope with all this kind of muscle injury, bleeding. So the management and you've been very calm, you didn't panic, and I think that's very important for everyone because you know the submucosa is, as Rosa said, it's a completely different skill. You have to orientate yourself, and it was so tethered to the rectal wall. So, you know, sometimes, you know, we have to go and do a full thickness, you know, dissection. In this case, it was a muscle injury possibly deep muscle injury. And as you told me, the patient had an uneventful recovery. He went home. So it's a part of the learning curve, and I think he did very well.
Thanks, Zach. Indeed, the patient did well, and the side checks were clear afterwards. The third case I did was a rectal lesion, which I did unblock. As you can see, this lesion is more obviously benign. It was again in the mid to low rectum. Took me 2.5 hours. Not a lot of fibrosis. Proved to be a low-grade polyp in keeping with our endoscopic assessment. It was a tubulovillus adenoma. I guess this case is ideal for SSD. I really did enjoy it, and this is a closer look, the mucus and everything, typical for a tubulovillus lesion. And this is the outcome in the end. Again, that was an unblocked resection. It was only my third case, so I think it's a pretty good result, although it's a benign polyp. It's not a small one. And again, I don't think unblocked resection with EMR would be easy in this case to achieve.
And from memory, I think you being by yourself on this one. There was no mentoring on this case.
For this particular case, you're absolutely right, Zach. Yes, I was on my own. I did have a very skilled nurse assistant, basically, who knew the platform very well and had seen quite a few cases. So this is also important. But I didn't have another operator next to me. Now, this next lesion was resected and blocked. It's a very low rectal lesion that came through bowel cancer screening. Apologies for the blurriness in the picture. But as you can see on picture number 2, there is a bit of disturbance in the pit pattern, which is quite worrying there. Apart from the JNet2B in the more anal part of the lesion, there is a bit of a loss in vascular pattern on this proximal island there. Very young patient, came through Bowel Scope. Bowel Scope is a screening program in England that used to invite patients when they were 55. So I did the assessment myself, and obviously I scanned the patient because I was concerned about cancer. The scans were all clear, didn't show any T3 or more lesion in terms of bowel wall invasion, no lymph nodes, no distal metastasis of concern. And basically in that case, my feeling was I was probably doing a diagnostic ESD, as you said, Zach. Now on hindsight, this is what I'm feeling like. But I did discuss it with the patient. I think it was perfectly reasonable to attempt an ESD in this case with a view to unblock resection. Worst case scenario, you have a very good specimen for staging, and obviously you've given the patient a chance to spare his rectum from a potentially significant surgery as a first step. So indeed, the patient proved to be a cancer. It was an SM1 without any adverse features, apart from the lack of clearance of the deep margin for 1 millimeter or more, which is, as you know, a prerequisite for a curative R0 resection in the UK, at least. We had a very thorough discussion with the patient after we had gone through the case in our multidisciplinary meeting with surgeons, oncologists, and radiologists. And the options were narrowed to 2 in the end: either radiotherapy for completion or a scar resection by means of TEMS, which is transanal endoscopic microsurgery performed by the surgeons. Basically a full thickness procedure. This was what the patient opted for. We did it, and there was no residual disease on the specimen. And the patient since has had 2 clear side checks, 6 and 12 months. So overall, good outcome. Yes, it was a cancer. We didn't have the clear margin in terms of depth. But in the end, I think the patient was managed very well. And this highlights the importance of good collaboration and understanding and trust between disciplines in the multidisciplinary meeting. And unlike UCL or Kent, where these have been very, very well developed, before I started doing SSD in my trust, all these cases were discussed in the colorectal MDT setting, often without a gastroenterologist. That means maybe decisions were a bit more aggressive in terms of surgery than they should. Nowadays, we've got a very good rapport, trust. We've discussed these cases, and as you all know, TEMS isn't perfect either. So I think approaching this polyp on hindsight has not been a wrong decision with SSD. This is a more close look, and this was the defect on the day. If you remember, Zach, you mentored me for this case physically, and there was a last in the center of the picture. There was this sign that resembled the one that Rosa showed earlier on, and we did discuss this is possibly muscle traction sign. I wasn't very confident in going through it, and I remember you took the scope for a couple of minutes, and you took that leap of faith, controlled, and you did dissect this area there a couple of millimeters, and the polyp was all freed afterwards without any complication. So I'm not sure if that was actually the muscle or a lot of fibrosis because of the malignant nature of the polyp.
I think possibly it was a fibrosis. That's why I think it was not. I mean, the pathologist couldn't see the clear deep margin because of there was no submucosal. It was only fibrosis.
Yes.
And that was really made difficult. So I think it went through quite a few committees to see,
correct,
and second and third opinion to identify the invasion, because it was, that's very gray zone where we cannot see, if it's pathologically, at least under the microscope, if it's like 0.6 millimeters, or the entire submucosa, it's impossible. I think the patient had a great outcome. It was again challenging, and you had the muscle traction sign. That was the one, which is more malignant than actually. That's why we had this discussion afterwards. But I think, Joseph, from your side, what I found very interesting, and I learned from you, is, when you spend 3 hours to 4 hours and you dissect a big lesion, and then there's a time constraints, and there's the colleagues are watching and attending, and I think you don't realize how really well you perform. So what I did advise you, I think on the first case, go back and look your case, go back and look what you have done, and I think then you realize how nicely you're performing. You couldn't believe that it was yourself, and I think because there's too much pressure, too much stress. And that's why the case selection, I'm going back to Rosa, our comment, I think it's very important from my point of view, is we need to share with the mentor the cases before. It should be assessed by you, by us, if possible. If it's a rectum, yes, definitely, this can be done for better assessment, rediscussion with the surgeon, and then you take out all this pressure, that you had for the lesion, because there are many factors that can give you a negative impact on that day, but when you see your performance, you're really very satisfied. So, and I think my question to you is that would you this laser, for example, would you attempt to use any monopolar knife at that tiny, very, very tight fibrosis?
Honestly, Zach, I haven't been trained in standard DSD. I mean, this was my first and my go-to device now for submucosal work. So even if I had another device there, I wouldn't contemplate using it. And you know how stressful this time can be. The last thing you want to do is experiment with other things. So sure. This is my take, basically. That's why I didn't think about it.
All right. Rosa, do you want to have any comments?
Joseph, I know that you were trying to go through cases with Zach, and then the pandemic just was bang in the middle, and especially here in the UK, we had a lot of restrictions traveling and going from places to others when we were in the middle of a heat wave. And I heard that you had a very good experience with remote training with Zach. Do you want to share it with us?
Absolutely, Rosa. In fact, I've got a picture later on, but I can give you an introduction. Basically, recently, instead of going old school and using whatever means you have in the room, like phones or FaceTimes or WhatsApps, we've got a very handy platform called Proximi that was kindly provided by Creo, and allows, apart from auditory feedback, of course, It has the means to provide visual feedback and guidance by the mentor on real time on the screen. So for example, when you have difficulty identifying the planes, which is basically the million-dollar question during submucosal dissection, this is when your mentor can step in and show you where things may be safer and where not. I'll show you what I mean later on. I've got a representative screenshot of how the setting is in my room nowadays. And to be honest with you, although I love seeing Zach and take him out for dinner after physical mentoring, now with COVID, I think we're going to stick with the proximity. It does the same. It's giving us the same benefits. So
mutual feelings.
Yes. So this is it, actually. This is a screenshot from a recent couple of cases we did in Northeast. Obviously, you have your screen in front of you, the monitors, the patient, and on the right side of my stack, I have installed the proximity platform. On the picture right on the very right, you can see a purple hand on the screen. This is actually Zach showing me where the plane is probably safer to dissect through. And you do have the sound. It's obviously it's been approved by my governance team. There is no patient data shared. It's basically just the lesion and the whole device setup, and you just crack on as if you had Zach next to you. Apart from the kicks and the slaps you may get if you do something wrong, the proximity is basically a very good representation of his mentorship.
Absolutely. I mean, yes, there are quite a few now platforms, commercially, and I think that's the future for the mentoring. That can really strong, can support, can discuss. You may have also one-to-one. You may have also share the, with the room, so you can see the room view, you can see the end view. I think this is really very handy, very handy.
Thank you, Zach. I mean, overall, my experience is obviously less rich than Rosa's and Zach, but I feel quite confident. I've got mentors. We discussed the cases before and after. These guys are available. It's important to have somebody available to discuss this informally, because the multidisciplinary meeting can get a bit stressful sometimes when you have all these disciplines around you. My learning point so far is pay a lot of attention in assessing the lesion, perhaps yourself before actually performing it. And obviously make sure you have your team trusting you and on board, because even in a smaller hospital, which is basically my hospital, it's a DGH, although it's a university hospital, it doesn't have the disciplines and the open-mindedness that maybe the UCL has in London or other hospitals elsewhere in Europe or the States or Asia. But I have now achieved this trust between the team members, and the referrals are increasing. Technically, my skills are improving. I feel confident, and it's important to share this thing with you. I mean, it's an amazing journey.
Thank you very much, everyone. I think it's been a great discussion, and thank you for sharing your experiences and your journey so far. It's certainly generated a number of questions, which if we've got a few minutes now, if I could fire them out to you just to see and answer the people from the floor's questions. First one came from Dr. Reiche, and this is for you, Rosa. It was, had you had any training in ESD and traditional ESD prior to starting with the SSD journey?
No, I didn't. I would have loved to, but because of personal and professional circumstances, never managed to sort of put a block of decent time aside to get trained on sort of a traditional ESD that maybe Zach had the opportunity to do before. So I had watched cases being done of ESD, because one of my upper GI interventional gastroenterologists in the hospital was performing ESDs in the stomach, and because I had an interest to learn on the technique, I watched him perform several times, but I didn't. My first time in the submucosal plane was with the Speedboat.
Okay. Thank you very much. Another question from the floor was, and I suggest, Zach, if this is to you, in comparison with traditional ESD, which I know you've done with the IT Nano and some other variations of devices previously, how long does your SSD take on average, polyp size dependent?
I don't, usually I don't have any comparative studies, so I can give a right answer. But what I can tell you is that given the safety profile of the device and the fact that you can encounter any fibrosis and any bleeding, I have the impression, and that this is only an impression or an assumption, that I'm getting faster with the SSD compared to the ESD. But again, this is only an assumption. It's not, I don't have any evidence for that. And also on this note, I think the reason that the Speedboat submucosal dissection seems to be a bit faster is because the Speedboat inject device facilitates the tunneling technique. And I've got these comments from really expert colleagues from Japan that the whole design and the whole safety profile advocates the tunneling. And tunneling per se, to my eyes, is when the tunneling has been completed or achieved, then the completion rate is more than 90%. This is something which I can definitely share with our colleagues. And as we proved earlier, the learning curve, because I've been to the learning curve of a traditional monopolar knife, and quite interesting, it took me a couple of years to go beyond the rectum. And you can see colleagues now that in more than 20 cases possibly to move outside the rectum. You can see now colleagues Rosa, Joseph, they're actually performing within 2 or 3, 5 cases. They perform brilliantly. So yes, it's not about the time, it's about the technique, the tunneling technique, which is very important. And I was not able, maybe it was my skill set, to perform easy tunneling with a monopolar knives, and also the safety profile, which my attribute to the time. We do have analyze our data of around 100 cases, and we have found that the tunneling is closely associated with the time of the procedure. It can predict the time, and it can actually have a really remove in a timely manner, but we don't have the data already yet. That will be soon published.
Okay, thank you, Zach. And to you, Rosa, I had a question. Both yourself and Joseph mentioned about doing hybrids in your first few cases. Could you just discuss, was that time within the hospital dependent? Was that polyp dependent, or device or something else? What was the reason for needing to snare those polyps off?
No, I can go first. Probably was a combination of the both. So there were a few cases that it was polyp dependent because there was a muscle retraction sign, so the muscle going to inside the polyp and making difficult to identify the planes in a couple of cases, and in the other cases it was time. Because obviously you have a limited amount of time to perform the dissection, and the lesions were large and in a difficult position, or maybe were lesions that were very vascularized, so you had to spend a lot of time coagulating with the microwave setting of the Speedboat inject, a lot of blood vessels that sort of slow you down because of the characteristics of the polyp. So a combination of both.
Similar experience here, Rosa. I mean, I've done 6 cases. I mentioned 3 were completed with the help of a snare. Time was the main issue, basically, because I mean, we do have anesthetists around us, and anesthetists can get quite busy sometimes. It's the logistics of using the room. COVID and the backlog has made things a bit more tense recently, so it's mostly time, basically.
Thank you. Just to wrap up for the last 5 minutes, just final couple of questions, both to you, Rosa and Joseph. Having your time again, going back through this learning journey, what would you have done differently, knowing what you know now?
Let me go first in this one. Very good question, Andy. And I'm thinking about it after each case, basically. I would summarize this in a couple of points. First thing I would do is I would have aimed to do a few more cases in a shorter amount of time. Obviously, there were some issues with the pandemic, and the resources became very, very sparse, and we had to be very careful on utilizing our time and offering bread and butter work to the trust, to the hospital. But I believe that I would have benefited more by doing more cases in a shorter amount of time rather than spreading and waiting between cases, because at least at the start of your learning curve, when you need exposure and you need challenges and you need to have troubleshooting fresh in your head before advancing your skills. And the second thing, which I mentioned a few times during my part of the presentation, is lesion assessment and therefore selection. It's important to assess the lesion very, very thoroughly prior to dedicating 2 or 3 hours and an expensive room to perform an SSD. So I would advise anyone who is a starter to assess the lesions themselves with the help of their mentor.
Thank you. Rosa, anything to add from your point of view?
Probably when I embarked into the journey, everything was sort of starting and didn't probably fully realize what I was signing up for. And I think my advice to future takers would be to really set aside the time to get trained and mentor and have the sort of a mental frame to go for it, because it's a technique that is very new. It's like learning to walk again. Even if you are an advanced EMRist, you feel a little bit unsafe at the beginning and with lack of confidence. And I think dedicating proper time rather than trying to do it along with trillions of thousands of things at the same time, it takes an advantage on the rapid sort of a progression. So take it sort of seriously and take it as another milestone that you want to achieve. So probably that would be my advice.
I agree with you, fully agree with you, Rosa and Joseph. Commitment, engagement, and hopefully, Rosa, it was not me that you have any regrets when you had the first cases. That was not me the problem.
No. I mean, it was great.
Do you have any second thoughts?
it was great to have you, but it's that sometimes maybe because your naivety as what an ESD involves and the submucosal space involves, when you sort of assign for it and say, yes, I think that's my next step to be able to offer our patients a sort of all the endoscopic modalities that are available, probably I didn't realize the amount of dedication that was needed, and I don't regret it at all. But I think I just want to convey the advice that make the time, and also people around you to understand that you are going to go through this process, so you feel fully supported as well, because the cases that you may put at the very beginning may take 2 or 3 hours, and otherwise you would be doing maybe 3 or 4 large EMRs that other colleagues need to help you to take on board in their lists in order to allow you to to progress on your ESD. So that make sure that you involve as many people as possible, because you'll need the support.
I think what you just described very nicely, the change of mentality, because it's about mentality to go to the new era of SSD. And I think that takes time. That takes time in terms of, as you say, you need the time, the commitment, the engagement, but there's a mentality shift that you do from the advanced EMR to the submucosal dissection and SSD. Thank you.
Brilliant. And one final question, Joseph Fraser, where do you see this journey finishing? How far around the bowel would you like to get?
Andy, recently I did my first sigmoid lesion. I mean, having seen Zach's cases, I mean, he does lesions anywhere around the bowel, and obviously one of the selling points of submucosal dissection is resecting lesions anywhere in the colon. I mean, my goal is to reach the cecum and back, you know. How long it will take, I think it will depend on how vigorous we'll be in doing the cases and how we'll manage to increase our workload, because I think after a certain point, your learning curve takes off. It's all about gathering the first few cases. And although the proximal colon sounds scary and you may feel, yes, there is a high risk of perforation, but it might be you encounter less bleeding. So there is a bit of a give and take there. So my goal is to go proximally to the rectum for now, deal with my sigmoid, and then go deeper.
Thank you.
I'll be a bit more philosophical. I don't think there is an ending, even when I am 6 feet under. So if we believe on what we are doing and setting up services for better patient care with development of technology that will probably go beyond our existence, there's no ending. So I'm happy to be involved on learning and constantly progressing. And hopefully when I go, it's not going to be even noticed, because we will have been able to transfer the knowledge to other generation and newcomers that can continue the work that we are trying to do. So hopefully no ending.
Absolutely. Thank you so much. We've come to the end of our time. I really want to thank the faculty for their time and their insight and sharing their knowledge and expertise. If you have enjoyed the webinar, we will be emailing out a link so that you can rewatch it again or share with colleagues or anybody else. If you have any questions, then please either visit our website at creomedical.com, or you can respond to the email that we're sending out if you wish any further information. And just one final point, both Dr. Zach and Dr. Rosa will be doing live cases in the coming months, one at the Kent course live, which is later this month on the 29th and 30th, along with a hands-on day. And Rosa's will be looking to do a speedboat case at London live from UCLH in October. I think it's the 26th, is that correct, Rose? November, sorry, November. So yeah, so please, if you want to log in and watch them suffer and be under stress and duress, then by all means, and see the speedboat working. But I've had no more questions from the floor. I just want to say thank you very much for that time, and I wish you a good evening.